Many thanks to the organizing committee for the invitation, my friend Dr. Xepapadakis and Dr. Managoudakis, and I would like to ask the President, Dr. Xepapadakis, to invite the next speaker.
Professor Tinterri, aspettiamo. Buongiorno.
There's a problem. Sorry, but there's a problem on the slides. There's a problem with the slides, sorry. Okay. Okay. Thank you. Thank you for the kind invitation, Professor Venizelos, my friend Gregorio Xepapadakis and Lazzaro Papadopoulos. I'm very happy to stay here, and this is a big issue, I think, the de-escalation today in breast surgery, especially in the axillary surgery, especially after neoadjuvant chemotherapy. Today, the neoadjuvant chemotherapy is 30% of the patient that we treat in a normal breast surgery generally. And the key points of this presentation and this study is the importance of residual axillary disease, the residual axillary tumor burden post-NAC. The American guideline, this is the American guideline, and the American surgeon is very clear on the position in this kind of patient that is treated with preoperative systemic therapy. And you can see that any kind of residual tumor burden, the American breast surgeon decide for the axillary dissection, but we have a really different kind of axillary tumor burden. I think that another important point when we treat this kind of patient is another important local regional treatment, that it is radiotherapy. And you can see in the same guideline that the radiotherapy is mandatory in this kind of patient, so is another treatment in case of this patient, and especially on the axilla. So we don't, it's very important to remind this. We have different kind of residual tumor burden with different outcome, with different oncological outcome. This is an ICARO study that define the outcome of the ITCs after neoadjuvant chemotherapy, and it's a multi-center international study that retrospective oncological study. And you can see in this slide that there is a difference in terms of survival in this patient after 5 years if you don't remove the axillary in this kind of patient, and there is not risk of regional recurrence after 5 years. So the Italian guideline about this problem in patients with CN1 status prior to neoadjuvant chemotherapy, this is the Italian guidelines, and after downstaging with the chemotherapy to have negative disease, we perform omission of axillary dissection, but only the analysis of sentinel lymph node when 1 or 2 tracer, 1 clips is the same. But for patients who remain tumor burden, we today don't have a clear support evidence to omitting axillary dissection in this kind of patient. All we know that this study of Memorial Sloan Kettering in 2018 that report a high number of incidents of additional macrometastasis in patients only with micrometastasis. But at the same time, at St. Gallen, many panelists, the 60% of panelists, was opposed to axillary dissection in case of micrometastasis. And also the Italian breast surgeon, the ANISC group, did not consider micrometastasis for routine axillary dissection. So we need, in this confusion of opinion, I think that we need a study to define, evaluate in this kind of patient with micrometastasis if it's good or not to perform axillary dissection. And so in Italy in 2020 started this multicenter Italian trial. The name is Neonode 2. In case of breast cancer, T1, 2, 3 with N plus at the diagnosis for preservation of axillary lymph node in presence of up to 3 micrometastases in the sentinel lymph node. It was a multicenter Italian trial because we think that many regions, many hospitals is better than a mono study. The number of patients to enroll today with our statistic, we think that it's necessary a lower number in the experimental group of this patient. The primary endpoint was the recurrence-free survival, and the secondary endpoints overall survival and the distant metastasis. This is the study design. You can see the state of oncological patient, and after chemotherapy, the patient was N0, clinical and with echographic examination. Any kind of surgery, we submitted this patient conservative and mastectomy, and we have 3 groups of patients. The patient with macrometastasis in sentinel lymph node, and this patient was submitted in axillary dissection. Patient with node-negative sentinel node and no axillary dissection, also the ITC in this group, and the experimental arm is not randomized trial, and patient up to 3 micrometastases, we don't perform axillary dissection. This is the inclusion criteria, 18 to 75 years, any kind of tumor size, T1, T2, T3, but positive axillary lymph node previous the treatment with chemotherapy. And in a good examination, I think it's very important, a good examination with ultrasound. The patient was submitted to neoadjuvant chemotherapy with the negativization of axillary lymph node after another clinical examination and ultrasound evaluation. This is other inclusion criteria: current pregnancy, inflammatory pathology or in situ, comorbidities, and other malignancy inside previous 3 years. Very important is the evaluation of the treatment. The treatment, this patient was submitted any kind of surgery, not only conservative, but also the mastectomy, and following surgery, based on biopathological characteristics and guidelines criteria, the patient received no other additional surgery, adjuvant radiotherapy, adjuvant medical therapy, hormone therapy, or biological therapy. Each patient will be discussed in MDM meeting in the breast unit. Another important point of this study is the participation of the radiotherapist. You know that there is not a big number of de-escalation study from the radiotherapist in the world. So this is one of this, and in this study there is a group of patients experimental will not undergo irradiation of the axillary region after this interpretation of the data. After conservative surgery, radiation volume will include only the breast with the boost, and after mastectomy, chest wall and the boost. This is the follow-up. Patient will be monitored as follows: a clinical examination every 6 months for first 5 years, a mammogram and breast ultrasound annually, and axillary ultrasound annually. This is the center that today in Italy perform this kind of trial. The active center were 29, 24 enrolling active centers, and 5 is in initialization. And this is the number, the preliminary number, because we have a big problem with COVID at the first of the start of the kickoff of this study. Today, this is the number of the experimental group, 51. The group 2 standard saw the patient with axillary dissection 2027, and the comparative with only sentinel node for negative sentinel node 82. This is a slide only for the friend, sorry, but for Lazaros and my friend Gregory, this is really confidential evaluation because it is an interim analysis, so really secret. But after 34 months in the group of experimental patients, we don't have local recurrence, distant recurrence, or mortality. So this is the previous and really preliminary data, but I think it's very important don't have event in this kind of study. Thank you for kind attention.
That's very kind. Thank you very much for your presentation. Shall we allow a few questions if somebody has one?
Yes, this data is really, really private, so please don't defund, because it's a little gift for my friend.
Perfect. We're waiting for the results then. Thank you very much. Διάλειμμα. Όχι. Συνεχίζουμε.